If you are over 50 and you have noticed that something has changed, not just with your prostate, but also with your desire, your drive, your interest in intimacy, I want you to stay with me for the next few minutes. Because what I am about to explain is something most men discover far too late, and in many cases, by the time they figure it out, years have already passed. Years where they assumed the wrong thing, treated the wrong problem, or simply accepted a situation that did not have to be that way. My name is Dr. Katharina Neumann. I have spent more than 20 years working with men over 50 on issues related to hormonal health, urological function, and sexual well-being. And if there is one thing I have seen more times than I can count, it is this. A man comes to me complaining about his prostate. We talk about his symptoms, and almost as an afterthought, sometimes embarrassed, sometimes unsure whether it is even worth mentioning, he says something like, "And I have also noticed that I'm not really interested in sex the way I used to be." He says it quietly, like it is a separate issue, like it is probably just stress or age or something he simply has to accept. But here is what most men do not know. These two things, prostate enlargement and the drop in sexual desire, are not separate problems. They are, in most cases, two expressions of the same underlying process happening inside the body. And understanding that connection changes everything. It changes how you think about what is happening to you. It changes what questions you ask your doctor. And in many cases, it changes what options you have. So let us start from the beginning. Most men first hear the word prostate somewhere around their 40s or 50s. Maybe a doctor mentions it at a routine checkup. Maybe a friend starts talking about getting up 3 times a night to urinate. Maybe they notice it themselves, a sense that the bladder never quite empties, a weak stream, a hesitation before things get started. This is what doctors call benign prostatic hyperplasia, or BPH. The word benign means it is not cancer, but benign does not mean harmless, and it certainly does not mean comfortable. The prostate is a small gland, roughly the size of a walnut in a young man, that sits directly below the bladder and surrounds the urethra, the tube through which urine flows. When this gland begins to grow, which it does in the vast majority of men as they age, it gradually squeezes that tube. The result is the symptoms most men are already familiar with: frequent urination, urgency, weak flow, interrupted sleep. But here is what rarely gets discussed. The prostate does not grow in isolation. It grows in response to hormonal changes that are happening throughout the entire body. And those same hormonal changes that are causing the prostate to enlarge are also simultaneously affecting the brain, the nervous system, and the mechanisms that control sexual desire. This is not a coincidence. This is biology. And most men sitting in a doctor's office never hear this explained. They walk out with a prescription for their prostate symptoms and go home still wondering, privately, why they no longer feel like themselves in the bedroom, and assuming that one problem has nothing to do with the other. It does. It has almost everything to do with the other. Let me explain the hormonal side of this, because I want you to understand what is actually happening, not in complicated medical language, but in terms that make sense. As men age, testosterone levels gradually decline. This is well known. What is less well known is what happens to that testosterone as it declines. Inside the body, testosterone is converted into other hormones. One of those conversions is particularly important here. An enzyme called 5-alpha reductase converts testosterone into a hormone called dihydrotestosterone, DHT. And DHT in the prostate is one of the primary drivers of prostate growth. The more DHT activity there is in the prostate tissue, the more the gland tends to grow over time. Now here is where it gets interesting. At the same time that DHT levels in the prostate are influencing growth, testosterone levels in the bloodstream are often falling. And testosterone is not just a reproductive hormone. It is a hormone that affects energy, mood, confidence, and, directly, sexual desire. So what many men are experiencing is this. DHT is driving changes in the prostate, while total testosterone is declining in the rest of the body. You get prostate symptoms from one end of the hormonal process and reduced libido from the other end of the same process. This is why the two so often appear together. This is why the man who starts noticing urinary symptoms in his early 50s, so often around the same time or shortly after, begins to notice that his desire has changed. He is not experiencing two different problems. He is experiencing one hormonal shift from two different angles. And here is something that makes this more complicated. Some of the medications most commonly prescribed for prostate enlargement, particularly a class of drugs called 5-alpha reductase inhibitors, which work by blocking that enzyme I mentioned, can reduce DHT throughout the entire body, not just in the prostate. And reduced DHT does not only affect the prostate. It can also affect libido, erection quality, and sexual sensation. This means that in some men, the treatment for the prostate problem can itself worsen the sexual symptoms. Not in everyone, not always significantly, but it happens often enough that every man taking these medications should know about it, and most are never told. If you are currently on medication for your prostate and you have noticed changes in your sexual desire or function since starting that medication, this is a conversation worth having with your doctor. Because there are options. There are alternative medications, different dosages, and combined approaches that can address the prostate without the same degree of hormonal impact. But you can only have that conversation if you know the connection exists. Now I want to talk about something that goes even deeper than hormones, because the hormonal link is important, but it is only part of the picture. There is another factor that connects prostate health and sexual function, and it involves the blood supply and nerve pathways in the pelvic region. The prostate, the bladder, the penis, and the muscles of the pelvic floor are all located in a closely connected anatomical zone. The nerves and blood vessels that serve sexual function run directly alongside the prostate. When the prostate is enlarged and inflamed, as it often is in men with BPH, this can create a kind of chronic, low-level tension in the surrounding tissue. The pelvic nerves become sensitized. Blood flow in the region can be compromised. The normal signals that travel between the brain and the genitals during arousal can be subtly disrupted. This is not a dramatic, sudden event. It is gradual, which is exactly why so many men miss it. Think about how it typically unfolds. A man in his early 50s starts getting up once or twice a night to urinate. He is tired, his sleep is fragmented, he feels less energetic during the day, his mood is a little lower. And somewhere in that slow decline of sleep and energy, he notices that his interest in sex has faded. He assumes it is the tiredness, or the stress, or the fact that he is getting older. And partly, he is right, those things contribute. But underneath all of them is a prostate that has been quietly growing, quietly compressing surrounding structures, quietly disrupting the hormonal and vascular environment that sexual desire depends on. The tiredness is real, the stress is real, but they are symptoms of the same root process, not the root process itself. I want to pause here and address something directly. Many men, when they notice a drop in sexual desire, feel a particular kind of shame about it. They do not bring it up with their doctor. They do not discuss it with their partner. They internalize it, wonder privately what it says about them, and sometimes begin to avoid situations that might make the issue visible. I have seen this pattern hundreds of times, and I want to say something clearly. A reduction in libido is not a character flaw. It is not a reflection of how much you love your partner. It is not a sign of weakness. In most cases, it is a physiological event, something happening in your hormones, your circulation, or your nervous system that has a medical explanation and very often a medical solution. The men who struggle most are not the ones with the most severe symptoms. They are the ones who wait the longest to talk about it. If you recognize yourself in what I am describing, the prostate symptoms, the changes in desire, the assumption that these things are separate and unrelated, please do not wait. Not because the situation is urgent in a frightening way, but because the longer these processes continue without being addressed, the more entrenched they become. Early intervention produces significantly better outcomes than intervention that comes years later. Now I want to give you something practical, because understanding a problem is only useful if it leads to action. There are several things that can support both prostate health and sexual function simultaneously. Approaches that address the underlying hormonal and vascular environment rather than just managing symptoms. The first is something almost every physician would agree on, but that almost no physician spends enough time explaining: the relationship between body weight, insulin sensitivity, and the hormonal environment. Excess body fat, particularly fat stored around the abdomen, contains an enzyme called aromatase. This enzyme converts testosterone into estrogen. In a man with significant abdominal fat, this conversion can happen at an accelerated rate, which lowers available testosterone and shifts the hormonal balance in ways that worsen both prostate symptoms and libido. Reducing abdominal fat does not require extreme measures. It requires consistency. Moderate changes in diet, particularly reducing refined carbohydrates and sugar, combined with regular physical activity, can shift this hormonal balance meaningfully over a period of months. The second factor is pelvic circulation. The blood vessels that supply the pelvic region, including the prostate and the erectile tissue, respond to the same things that affect cardiovascular health generally. Men with high blood pressure, elevated cholesterol, or early signs of arterial stiffness often find that sexual function is one of the first areas affected. This is not coincidental. The arteries that supply the penis are among the smallest in the body. They show signs of compromise earlier than the larger vessels. A man whose sexual function has declined significantly may be receiving an early warning about his cardiovascular system. A warning that should not be ignored. Improving cardiovascular health through exercise, dietary changes, blood pressure management, and where necessary, appropriate medication, can improve pelvic blood flow. An improved pelvic blood flow supports both prostate tissue health and erectile function. The third factor is sleep. I mentioned earlier that prostate symptoms disrupt sleep, but the relationship runs in both directions. Poor sleep, regardless of cause, lowers testosterone. In men who sleep fewer than 6 hours per night, testosterone levels the following morning are measurably lower than in men who sleep 7 or 8 hours. Lower testosterone reduces libido. Lower libido and reduced sexual activity can further affect mood and hormonal balance. This is a cycle, and breaking it requires addressing the sleep disruption at its source, which in many men over 50 begins with the prostate. This is why treating prostate symptoms effectively often produces an unexpected side effect. Men find that their energy returns, their mood improves, and their interest in intimacy begins to come back. Not because the prostate treatment directly affected their hormones in a beneficial way, but because sleeping properly again changed everything. There is one more thing I want to address, because I think it is the most commonly misunderstood aspect of this entire topic. Many men believe that a drop in libido at 50 or 60 or 70 is simply natural, that it is part of aging and therefore not something medicine can or should address. This belief causes a great deal of unnecessary suffering. It is true that testosterone declines with age. It is true that sexual desire and function change over a lifetime. But change and disappear are not the same thing. A significant and distressing loss of sexual desire is not an inevitable feature of aging. It is, in most cases, a symptom of hormonal imbalance, of vascular compromise, of medication side effects, of sleep disruption, or of some combination of these factors. Men who are 70 and report satisfying sexual lives are not experiencing a miracle. They are, in most cases, men whose underlying health has been reasonably well maintained, whose hormonal environment has stayed within a functional range, and who have addressed problems when they arose, rather than waiting and hoping. The decision to do nothing is itself a decision, and in this particular area of health, inaction tends to compound the problem rather than stabilize it. Let me bring these together before we close. Prostate enlargement and declining sexual desire are not two separate misfortunes that happen to arrive at the same time. They are, in most men, two visible signs of a single underlying shift in the hormonal, vascular, and neurological environment of the aging male body. The same hormonal changes that drive prostate growth, particularly the interplay between testosterone, DHT, and estrogen, also influence libido and sexual function. The same vascular changes that compromise blood flow to the pelvic region affect both prostate tissue and erectile function. The same sleep disruption caused by nighttime urination lowers testosterone and dampens desire. And the medications most commonly prescribed for the prostate can in some men directly worsen the sexual symptoms. Understanding this does not make the situation hopeless. It makes it navigable. Because if these things share a common origin, they can be approached with a common strategy. Hormonal assessment, cardiovascular evaluation, sleep optimization, informed medication choices, targeted lifestyle changes. None of this requires heroic effort. It requires awareness and the willingness to have an honest conversation with yourself and with a physician who takes the full picture seriously. If your doctor has been treating your prostate and your libido as two unrelated issues, you now know something important. They may not be unrelated at all. And that knowledge is worth bringing into your next appointment. The men who do best are the ones who stop accepting the separation and start asking the right questions. You now have the information to do that. Take it seriously. Your body has been trying to tell you something. It is worth listening.